We're going to launch our fall-winter webinar series today with Dr. Carolyn D'Ambrosio, and we're so happy to have her here because many of you have asked, could we have a talk on obstructive sleep apnea? And it's something that affects many of us and something that more of us should be aware of and keep on the lookout for. So Dr. D'Ambrosio is the director of the Fellowship in Pulmonary and Critical Care at Harvard Medical School and Brigham and Women's. She's an associate professor in medicine at Brigham and Women's and Harvard. And she's here today as a national expert in obstructive sleep apnea to tell us everything we need to know about sleep apnea. And as the usual, just to remind you, if you haven't been here for a while, we'd love to have your questions. Please address them in the chat. If you want to just address it to me or Dr. Kelly Hedgepeth, you can, or address it to everyone if it's of broader interest. There's also the Q&A form. Sorry, I should have said. The Q&A is where you should address your questions. But if you have something of general interest, you can also put it in the chat. We'll look in both. And after her talk, she's going to address some questions that people submitted over email and also questions that come in live. So without further ado, welcome Dr. D'Ambrosio, and thank you so much for joining us today.
Thank you for asking me to give this talk. I'm always happy to educate the public and answer questions for people who either think they have sleep apnea, know they have it, or struggling with it. So with that, I'm going to jump right in, and we're going to talk about what is obstructive sleep apnea. So basically, when you go to sleep at night, your muscles relax. And when you take a breath in, if you have sleep apnea, your upper airway, this part right here under your chin, your throat, just closes off when you're trying to take a breath. And that causes a reduction in your blood oxygen level. And eventually your brain figures out that you're not getting enough oxygen, wakes you up, so that's an arousal from sleep. And at that time, you also get a surge of adrenaline, that hormone that makes your heart race and raises your blood pressure. The symptoms with obstructive sleep apnea, the most common ones are snoring and daytime sleepiness, but I'll go over a few others as we go on. But a couple things here that are important is that drop in your blood oxygen level, it's just a small drop, but it's enough to cause a signal to be spread out, to cause long-term consequences with heart disease, high blood pressure, increased risk of heart attacks and strokes. And the adrenaline with it is a double whammy. So those things right there can lead to some health problems for people with sleep apnea that aren't, when it's not treated. And then the arousal from sleep, the waking up from sleep, is what makes you feel bad the next day when you have obstructive sleep apnea. You're not getting proper rest. So let's go over some symptoms of sleep apnea. I mentioned snoring. And the picture I have here is a bed partner who's a woman, often annoyed by the male bed partner who is snoring. That is the most common presentation, and actually it's very interesting. Very few women come in with a complaint of snoring. Now, is it because they don't snore, or is it because their bed partner is already asleep and doesn't hear their snoring? It's hard to know, but snoring is actually more commonly reported in men. Morning headaches. So if people wake up and they start their day with a headache, that's another sign of sleep apnea. Sometimes people will come in because their bed partner will say, I thought he or she was going to die. They stopped breathing. I had to shake them to take a breath. So witnessed apnea. And then a really common one is a dry mouth. They wake up and have to take a glass of water right away. And that's usually a sign of the mouth being open during sleep. There are a lot of reasons for dry mouth, so don't worry if you have a dry mouth and you don't have any other reason to have sleep apnea. But it is one of the more common symptoms we see. And then the other one is sleepiness and daytime sleepiness. So one of the ways we figure out if somebody's really sleepy is to ask them a series of questions. And this is one of the ones that's used most commonly across the country. It's called the Epworth Sleepiness Scale. And it asks you on a scale of 0 to 3 to rate the chances you're going to fall asleep in these settings. So how likely are you to fall asleep if you sit down to read something, or if you're watching TV, or if you're in pre-COVID days in a theater or a public place and just sitting around, you're a passenger in a car for a long drive, or if you lay down to rest in the afternoon? Then people who are really sleepy will fall asleep sometimes if they're sitting and talking to somebody in a car while stopped in traffic. That's a really sleepy person. Or sitting quietly after lunch if your lunch did not include alcohol. So on 0 to 3, you rank all of these. And normal, meaning that you're not that sleepy, is a total number, if you add them all up, of 10 or less. Over 10 means you're sleepy. And you can be sleepy for a lot of reasons. The most common cause in our society is sleep deprivation, or either not getting enough sleep because of our 24-hour society, or people on their devices late at night, all kinds of reasons for not having good sleep or not enough sleep. Sleep apnea being one of them. But this gives us a general idea of how sleepy somebody is, because people often feel tired or fatigued, but often if you ask them the questions, they actually aren't likely to fall asleep in these settings. So who gets sleep apnea? Well, obstructive sleep apnea is more common in men than in women overall. But after the age of menopause for women, their rate of getting sleep apnea increases and gets close to that of men. So a lot of women whom I have seen actually will notice that they start snoring after menopause, or they come in saying that they're more tired after going through menopause, and that's where we start picking it up. Now, the reason you have sleep apnea is that your throat collapses when you take a breath in during sleep. So if you put more weight on your throat when it's likely to collapse, it increases the likelihood of collapsing. So neck size or obesity increases your chances of having obstructive sleep apnea. So for men, a neck size is 17 inches or more. For women, it's about 14 or 15 inches. If you're higher than that, it does increase the chance that you might have sleep apnea. Some physical features can indicate that you're at a higher risk of sleep apnea, such as having a significant overbite. Other things are if you have a particularly large tongue, there are some facial structure differences that people are born with that can increase the risk of sleep apnea. And then it's often seen in families. So the question I ask people is, since it's more common in men, did your father, uncles, or your brothers snore and have heart disease? Those are sort of questions that I ask just to get a sense, because a lot of people don't know if their father, grandfather, or uncles had sleep apnea, but they'll know if they snored, and they'll know if they had heart disease. And so it's an easy way to sort of tease out whether or not this person has a higher risk of having sleep apnea or not. Some other things I look for when I talk to a patient about sleep apnea is whether or not they have a history of depression, particularly in women. Women are often diagnosed with depression and treated for depression long before somebody figures out it's obstructive sleep apnea. And the reason is women will say that they're fatigued and they're tired and they don't have the energy to do things they enjoy, rather than saying they're sleepy. Whereas men will come in, and it's often a spouse that will say he's falling asleep after dinner, or falls asleep when I'm talking to him, we have people over for dinner, one glass of wine, and he's asleep on the couch, something like that. Whereas a woman will come in and say that she's just lost the energy to do things she enjoys. And that sounds a lot like depression to a doctor. And so they will often have depression before they get their sleep apnea diagnosed. Reflux is a common complaint amongst patients with sleep apnea. Often patients will have impotence, male patients will have impotence, and female patients will have a loss of libido. And those are things they won't tell the physician unless we ask, or the healthcare provider unless we ask, but if we ask, it's there. A number of patients will actually come to the doctor, and they don't come to me, they come to their primary care doctor for anxiety, and anxiety specifically about falling asleep, or when they go to bed, they have a rush of anxiety. And that is often associated with that rush of adrenaline they get when they have the apnea. So they know something's wrong and they're anxious about sleeping, but they can't put the two together. For people over the age of 65, one of the #1 reasons they come to see a sleep doctor to be evaluated for sleep apnea is that they've lost their ability to do some simple cognitive tasks, like where their keys are, figuring out where they left their checkbook, being able to balance their checkbook, and They'll forget names of people they've known their whole lives. And so those are sort of indications to look at sleep. Now, there's a lot of reasons why people get forgetful or have cognitive issues after the age of 65, but sleep apnea is a treatable one. And then a big one is, again, something a patient might not mention to you or as a physician or a healthcare provider, but the needing to urinate at night. About 50% of people with sleep apnea will say they have to get up in the middle of the night to urinate. And this is before diagnosis. And men in particular will be told that their prostate's enlarged and get treated for that before anyone starts asking about their sleep or their sleep apnea. So untreated obstructive sleep apnea actually sets off a hormone cascade that causes more urine to be produced during sleep, which is why people have to get up and go to the bathroom in the middle of the night. And once we treat their sleep apnea, that improves significantly. And just a mention of women, I particularly wanted to make this mention because there is an increased prevalence and severity of sleep apnea after menopause. It actually triples. And then women on, I have HRT there, that's hormone replacement therapy. So if women going through menopause or after menopause are taking hormones, they have a lower chance of having obstructive sleep apnea. And there's a significant underdiagnosis of obstructive sleep apnea in women with a delay of up to 7 years. And 90% of women diagnosed with obstructive sleep apnea have significant delay. Maybe not 7 years, but they have a couple of years of delay before they get diagnosed. And women can have just as serious cardiac problems because of untreated sleep apnea as men. And it's often missed and not treated for a couple of years. So it is a significant problem that we have to address. People who already have cardiac disease are at a higher risk of having obstructive sleep apnea. So this is just some simple percentages. So people overall who have any form of heart disease, 30% of them will have obstructive sleep apnea. People who have CHF, which is congestive heart failure, 50% of those can have obstructive sleep apnea. If you do tests on people who've already had a myocardial infarction, an MI, a heart attack, 60% of those will have sleep apnea. Same thing for people who've had stroke. And then for patients who have what we call drug-resistant hypertension, which means high blood pressure that's really hard to treat, so they're on 2 drugs and their blood pressure is still really high, almost 83% of them have untreated obstructive sleep apnea when they're tested. So if you fit into any of these categories and you have any of those signs and symptoms I mentioned, you may want to talk to your doctor about getting screened for obstructive sleep apnea. Now, how do we test for sleep apnea? For those of you in the audience who've already gone through this, forgive me for taking the time here, but we start with a sensor up here on the head. This is an in-laboratory test. This tells me brain waves and what stage of sleep somebody's in and if they wake up from sleep. We also have EKG, so we can monitor the heartbeat and the heart rhythm. We have a cannula that goes in the nose, which measures airflow, right? Because obstructive sleep apnea means the air isn't getting in, so we need to measure that. We also have belts around the chest and the abdomen to show us if you're trying to take a breath, even though the airflow has gone down. Whoops. And then we also have an oxygen monitor on the finger. And then all these wires get sent back to a technician who's monitoring the patient while they sleep. So if you've had a sleep test, this is very familiar to you. And the question I always get from people when I show this slide is, how can anyone sleep with all that stuff attached to them? And it's a great question because the average person, if they're well rested, will have a difficult time sleeping with all that stuff attached to them. But a person with untreated obstructive sleep apnea is so tired that they just fall asleep and it's not that big a deal to have all that stuff attached to them. So this is what we see, and it's just a simple representation. So this is time here. So here you are breathing. This is your airflow. This is that belt around the chest and a belt around your stomach, and you're trying to take a breath, or your chest and belly are moving to try to take a breath. And the obstruction happens here where there's no airflow, but the belly and chest are moving, trying to take a breath. So your throat is closed off, but your body's still trying to get the air in. And then the oxygen, this is your oxygen level down here, goes down. So that's what we see on the sleep test to tell us that you have obstructive sleep apnea. You're trying to take a breath, but the flow isn't there, which means something's obstructing it. Now there's another form of a sleep test. So there's some home sleep tests that have less attachments than what I showed you for the in-lab test, but there's also this one here that some of you, if you've done a home sleep test, you may have gotten this one. And this looks like an oxygen monitor, but it does monitor oxygen level, but it also is like a little blood pressure cuff for your finger. And then it goes to your wrist here. It's like a watch, and you wear it when you sleep. And that tells us if you're moving around or if you're not moving around. And it senses that if you're not moving around, we assume you're asleep. And then it tells us if your blood pressure is surging, because remember when you have those obstructive apneas, you get that adrenaline surge that raises your heart rate, raises your blood pressure, and you get a drop in your oxygen level. So this one is also very helpful to determine whether or not somebody has sleep apnea. So you may see this one if you're getting tested, or you may have had it yourself. So we put the number of times you stop breathing called an apnea, or the times where your throat closes off almost all the way called a hypopnea together, and we divide it by the amount of time you slept, and we get something called an AHI, or an apnea hypopnea index. And if you do that 15 times or more during sleep, you need to get treated. Or if you do it more than 5 times per hour, 5 times per hour with sleep, and you have any of these conditions here, high blood pressure, you've had a stroke, you're very sleepy, you have heart disease, you have insomnia, or you have mood disorders, any of those with an apnea-hypopnea index of greater than 5 events per hour means you need to get your sleep apnea treated, okay? And so oftentimes people will ask me, well, I felt like I didn't sleep at all during that test. How can you say that I have sleep apnea? And one of the things that's interesting is that people with obstructive sleep apnea that's not treated have very little ability to tell whether they slept or not. They will say they tossed and turned all night and didn't get any sleep, but if we look at their brain waves, they actually slept. They just kept getting woken up from the apnea. So their sense is that they didn't get any sleep, but they actually did sleep. So some treatments for sleep apnea are this. So weight loss if you're obese, and weight loss is very difficult, even in the best of settings, and it's hard to maintain, but it will help some people. And in particular, if you've ever heard of somebody having a gastric bypass surgery for weight loss, those are the people who are usually very obese and they lose over 100 pounds. That can really help them and treat their sleep apnea. Alcohol or sedating medications make sleep apnea worse. So if somebody is actually using a lot of that, getting rid of those can actually help reduce the sleep apnea. There's upper airway surgery that can be done. We used to do tracheotomies, putting the hole right in the throat there, right into the windpipe. That was about 30 years ago. We don't do that anymore very commonly, but there are other surgeries we can do in your airway. Dental devices, which I'm going to show you a picture of coming up. CPAP is the #1, so that stands for continuous positive airway pressure. That's the #1 treatment. I'll show you a little bit about that coming up in a few slides. And then one that's newer to the market is something called the Inspire, which actually is like a pacemaker for the muscles around your throat. So remember, the reason you have sleep apnea is that your throat gets floppy and closes off when you're trying to take a breath and you're asleep. So what this does is it senses that you're trying to take a breath, and it stimulates those muscles around your upper airway and opens up your upper airway. So it's like a pacemaker for your throat. Everyone wants to know when we're going to get a pill for this disease, and unfortunately right now we don't have any evidence to say that there's a medication that's good enough for the primary treatment of sleep apnea, but there are some preliminary studies within the last year or two that are showing some promise for treating sleep apnea. We just don't have the pill on the market yet. Modafinil, or something called Provigil, is one of you may be on, or you've heard about it. It's a drug that we use to help people feel awake, and it actually is quite helpful because there's about 1/3 of people with sleep apnea that after we treat them and we feel like they're adequately treated, still feel really sleepy. So we give them this medicine, modafinil, to help them feel more awake during the day. Now, let's just review sleep apnea and then how CPAP works and why it's the mainstay of therapy. So this is a person here, and the blue arrows show how the air goes in when you take a breath in, and the red arrows show how the air goes out when you exhale. When you go to sleep and you have sleep apnea, the throat closes off right there when you're trying to take a breath, and there's no airflow either direction. And this happens when you're trying to inhale. So then you get CPAP, continuous positive airway pressure, which means there's a blue arrow going at all times. And that blue arrow opens up the throat. It just stents it open, right? So the throat's trying to collapse and the air is just pushed in and opens it up. And the way it works is you have a mask on your face that's connected to the CPAP machine, and the CPAP machine just pushes the air through that mask into your throat to keep your throat open. And you can actually exhale, so you can let your breath out because the amount of pressure going in is low enough that you can exhale against it, and then there's a little valve here that allows your breath to go out. So a lot of people say, am I going to blow up like a balloon, or am I going to suffocate? The answer to both of those is no. This is air that goes in to help keep your airway open, and you are able to exhale, and there's a little valve there that lets the air come out when you're exhaling. So that's how CPAP works. And the mask looks like this, but there are multiple different masks. So the most common one is this one here that just goes over the nose, and it has the straps that go behind the head, two different straps, one at the forehead level and one at the lip level, that go behind your head, and it goes over your nose. Now, some people, when they get this pressure going up into their nose, open their mouth, and the air goes right out of their mouth. And for those people, they need what we call a full face mask. And so that's a picture of this one here. So again, it has a strap at the forehead, and then this is now at the sort of at the mid-lip level. But the important part is the mask goes over the nose and mouth. So if they open up their mouth during sleep, the positive airway pressure will still get in and still open up the throat so they can breathe properly. And then this one is more comfortable and has less headgear. It just goes under the nose like this, but it completely occludes the opening of your nose. So it's a nice tight seal there. Some patients really like this because there's not a lot of stuff on their face, particularly if they're highly sensitive or have some claustrophobia, something like that. That's typically where we see people who really want to have something more like that. And this is the box. It's a small box. It's about the size of a coffee pot. Goes on the bedside table. And the only super hard thing I would say my patients tell me about this is the mask and tubing. This tubing and whatever mask you have has to be rinsed out with warm soapy water every morning and hung up like on a rack to sort of dry overnight, air dry, or during the day, so then you can use it the next night. That's sort of the one thing people sort of get annoyed with. The other thing that is a problem is the mask is uncomfortable. And I tell people all the time, do not give up just because the mask is uncomfortable, because we have several different types of masks. I'm just showing you 3 types here. But often the size isn't right, or it's too tight, or it's not tight enough, or something else can be adjusted so it's more comfortable for you and you're able to tolerate it. The mask should be comfortable but snug so that the air doesn't leak out. And some people with the headgear is a problem, so we work with them and try to find different headgear to hold the mask in place. So there's a lot of things a home care company and your sleep doctor can do to make the sleep apnea treatment acceptable to you. But there are other treatments, and we should mention them. CPAP is the first line treatment. It's the one that we all go to first because we know it works. It pushes air in and opens up the throat. So if you can tolerate it, we know it works. For people who can't tolerate it or who have other issues, we do have other treatments. They're just not the front line. So surgery is one of the treatments that we have. So if you open someone's mouth and you look in, this person has large tonsils. That's usually the cause in children or young adults, and getting rid of the tonsils can be helpful for treating the sleep apnea. But other people, if you look here, here's the teeth. teeth, there's the tongue, and there's the uvula. That's that little thing that hangs down the back of your throat. And air is supposed to flow through there, but you can see that's a small opening. So what surgeons will do is they'll cut off the uvula and take off some of this extra tissue around it and really open up the area for airflow. So that's one type of upper airway surgery that we can do for sleep apnea. So tonsils is number one, but that's very unusual. That's a young adult or child. This is called the uvulopalatal-pharyngoplasty, where they take out the uvula and part of the soft palate, and that opens it up. And that's good for people who are otherwise thin, do not have very severe sleep apnea, and don't have low oxygen levels during their sleep study. So there's very specific patient for whom this works. But if it works, it's great because you get it done and you don't have to wear a CPAP machine. Now, other treatments are the dental device, and that's what this is up here. So this is a replica of teeth, and the dental device is actually like the plastic covering of your lower teeth and your upper teeth. So it's like a lot of people have those plastic retainers now, similar to that, but the difference is it has a little hinge, so they're connected. And what this hinge does is it slowly over time is adjusted to sort of push your lower jaw forward. So what that does is tug your tongue off the back of your throat, and that opens up the upper airway. So when it's likely to collapse, that tongue is tucked forward, and so it's less likely to fall to the back of the throat and obstruct your airway. So the dental device works like this. You need to have all your teeth in order to be able to have that. You need to be able to tolerate it. Some people can't tolerate it. They just feel it all night and it worsens their sleep. And it is paid for by medical insurance if you've tried CPAP but can't tolerate CPAP. So that's one of the interesting things about the dental device, but that's more my go-to. That's a second line therapy for me often if someone can't tolerate CPAP. Again, it's better if the sleep apnea is milder, the patient is thinner, and they don't have really low oxygen levels. The patients who have more severe sleep apnea, have more obesity, or have really low oxygen levels during sleep, CPAP is really the treatment that's going to fix all of those, most likely. And then finally, I show you this picture because there actually was a study done in Australia looking at this musical instrument called the didgeridoo, and there's Nicole Kidman playing it. And actually, people with sleep apnea who played the didgeridoo for several hours a day for a couple of weeks, actually, by building up the muscles of their throat, actually reduced their sleep apnea. I don't recommend that for most of my patients. I had one who wanted to try, but I told him I couldn't put my stamp on it for approval. But it is an interesting thought that upper airway exercises may be something else we can add to this, although we don't have those yet. And then lastly, the thing I want to talk to you about is the Inspire that I mentioned. And that is the pacemaker for the muscles of your upper airway. And so it literally is like a pacemaker, goes under your skin, right by your rib cage. And it has a little lead that's embedded in your rib muscle here that can sense when somebody's starting to take a breath. It gets that information, sends it back to the machine, and the machine then sends a signal to the nerve that stimulates your muscles of your upper airway and makes your upper airway muscles stimulated and opens up your throat. So this is, again, it works really well in certain patients. The patients who have only mild obesity, who have moderate or mild sleep apnea, those are the ones that we normally try this on. The harm of this really is it's a device implanted, so it's invasive. It requires a surgery, and it's hard to live with that if you ever go, pre-COVID days, if you go through airports and things like that, you have this metal device in you, or an MRI, which is a test people sometimes have to get. You have this implantable device. So it's not for everybody, but it is something interesting that we've added in the last 5 to 10 years. So, but often what I see or hear, I get about a third of people on the follow-up visit after starting CPAP loving it, about a third of people who can give or take it, and then a third who come in pretty unhappy, saying this CPAP is a nightmare. and they have a multiple list of complaints. And these are just some of them. For those of you who may be experiencing this, there's nose congestion, and so there's nose sprays we can use, as well as antihistamines, over-the-counter antihistamines, to help reduce some nose swelling. Dry nose sometimes, and so there actually was somebody, I think one of the questions we got was somebody with a dry mouth. If the dry mouth, I want to make sure you have a full face mask before you do anything else, or a chin strap with a nose mask. But you can also use normal saline, which is salt water. It comes in a jelly form. You can use lanolin or KY jelly in your nose. Those are things you can use in your nose. There's also nose spray that's called ocean spray, so salt water like the ocean. But the thing you don't want to use is any petroleum jelly, no Vaseline or anything like that, because it damages the silicone in the mask, but it also can put you at risk for a particular type of pneumonia from a product in the petroleum jelly. So if this is you and you have a dry nose or dry mouth, normal saline jelly, lanolin, KY jelly, or just saltwater rinses, those are things to work on. Sometimes the pressure is too high, sometimes the pressure is too low. And so that's why it's very important to have a follow-up with a sleep doctor, so that we can walk through what all these different things are and whether or not changing any of those will make a difference for your ability to tolerate the treatment. Some patients tell me their eyes are getting dry, they're waking up with their eyes dry, and that means that the mask is leaking up into their eyes, and that actually isn't good. People can get some dryness of their cornea, and so that means we have to refit the mask right away and make sure that they have a good fitting mask. Other patients will say, or I always ask, because some people won't realize it's related to the CPAP, but they have a lot of belching in the morning, and that's because the air not only is keeping their throat open, but it's also going down into their stomach, so that when they wake up in the morning, they belch to get rid of that air. And we can change the CPAP pressure, change the way the machine works to prevent that. I ask always about the mask fit and make sure you're using it regularly, the chin strap and the full face mask, as I mentioned. And then sometimes we do all of this and we can't get anywhere, and we need to move on to a second line therapy like the dental device or the Inspire. There are some people who have a lot of anxiety about using the mask, and a psychologist can be helpful in that regard. Or other people have claustrophobia and they just need some relaxation techniques in order to be able to tolerate the mask. But for the most part, if I go through this list and I try to adjust all these things and the patient still is not able to sleep with the CPAP, then we move on to another therapy. Again, the type of therapy I would move on to is very individual, and I can't say what is absolutely the next best thing. Often the dental device works very well, and that usually is my go-to, but there are some people who surgery or the Inspire device might be the better therapy for them. And then, so just to summarize, sleep apnea is actually really prevalent in our society. Men are more likely to have it, but women increase the prevalence after the age of menopause. Obstructive sleep apnea is more likely in obese patients, but thin people can have it too. It is the upper airway collapsing during sleep. So it does not necessarily have to be an obese person. Diagnosis and treatment is imperative to prevent the adverse outcomes such as cardiovascular disease, motor vehicle accidents, and the cognitive deficits associated with it. So people with untreated sleep apnea are at a higher risk of motor vehicle accidents, not just from falling asleep at the wheel, but also from having blunted reflexes. So their reflexes are slower than normal, and they're actually somebody with untreated sleep apnea, their reflexes are worse than someone who's legally intoxicated on simulated tests. So we worry a lot about car accidents in people with untreated sleep apnea, and that's why I work really hard with my patients to make sure they get adequately treated. And then in the elderly population, the people 65 and older, we have seen significant improvements in their cognitive abilities once we get their sleep apnea treated. So there's nothing like a good night's sleep. And I hope all of you are well rested, and I'm happy to take any questions. I did want to I addressed one that came through early. I'm going to address the other two One was people were worried about the latest information from the FDA on the device that cleans CPAP machines, the SoClean. The FDA came out and gave a warning that these devices can release ozone, which is a chemical that is harmful to lungs. They have not rescinded the approval on this device, and they have not told us to tell people to stop using it. I tell people that they have to decide for themselves how scared they are of this. We don't have enough data for me to say absolutely stop it or absolutely it's okay. What I say is if you're going to put your device in the SoClean machine, turn it on and leave the house or the apartment for the day and not come back until later, you're probably okay. But if you're going to be in the same area as the machine when it's running, you are exposing yourself to this ozone chemical, and it may not be the best thing. So I leave it up to the patient on where their comfort level is. Again, this machine is not necessary. All you have to do is with the mask and the tubing, just rinse it out in soapy water and then rinse the soap out and let it dry. So you don't have to have one of those machines, and you're safe without it. It's not like you're going to get any infection or bacteria exposure if you don't use it. And I think there might have been one other question, but for the life of me, I can't remember what it was. Mm-hmm. So I will take questions from the chat or from the Q&A.
Perfect. Thank you. All right, so we have a lot of questions coming in. Thank you, everybody, for these questions. And you can address them, like I said, to the Q&A or the chat. But let me start just by saying thank you. That was perfect. And I think so many people here have been diagnosed with sleep apnea or have been diagnosed with heart disease or both. And let me start with a question. Is the relationship between cardiac disease and sleep apnea a causal relationship or only a correlation? And does treating sleep apnea reduce the risk?
So I think the majority of us feel that it is part of the cause of cardiovascular disease. So it's not the full cause, whereas if you don't have any of the other risk factors, your sleep apnea is going to be the thing that leads to your stroke. But if you have other risk factors for heart disease and you keep having low oxygen levels and adrenaline surges during sleep, that increases your risk even more. So we think it's part of the puzzle, but it's not the only puzzle. But yes, treating your sleep apnea, several studies have shown improvement or reduction in cardiovascular events. There are some that show no change, but a good number of them, and most of us who practice this believe that it is preventative by treating your sleep apnea.
That's great. And you didn't even mention atrial fibrillation, which I think is a newer, more newly recognized fact that sleep apnea is a major risk factor for atrial fibrillation. And I've seen a few patients whose atrial fibrillation went away once they got their sleep apnea treated.
Absolutely. Yeah, I should have mentioned that. So if you have atrial fibrillation, you have 70 to 80% chance of having sleep apnea, and treating the sleep apnea can treat this atrial fibrillation.
Great. I'm going to ask one more and then I'll pass it on to Dr. Kelly Hedgepeth. What about the position that someone sleeps in? Whether or not they're using CPAP, should they sleep on their side, their stomach, their back? What's best?
You should sleep where you're comfortable. So I know that there's a lot out there in the sort of the wellness community about you should sleep on your, I think it's your left side or something, improves all kinds of things. But we really have not, number one, we've not shown that scientifically. And number two is that the thing we have shown scientifically is that it's incredibly difficult to change somebody's preferred sleeping position. So some people, their sleep apnea is worse on their back, and we've done all types of things to get them to train themselves to sleep on their side because their sleep apnea is less, and they always go back to their back. So being comfortable is one of the most important things to getting a good night's sleep. And so I tell my patients, sleep in the position where you're most comfortable, because that will help you get into the deeper stages of sleep.
Okay, great. You know, you could actually stop sharing your screen too, and then we can see you a little better.
Of course, yeah. No, sorry, I thought there we go.
Nice. So this is so fun because I think this is an area of medicine where, the pulmonary, the lungs and sleep really intersects with cardiac. So yeah. I think as cardiologists, we get so many questions about this. And as the guidelines have changed, right, the patients that have heart failure and the patients that have atrial fibrillation, as well as all the patients that have high blood pressure, right, are really, we're really focusing more on their sleep, their quality of the sleep, if they're rested, and it's so complex. So just maybe your bird's eye sense, because I think when we ask most of our patients, you know, how you sleep, most people don't say I sleep perfect. You know, most people have some signs that their sleep could be optimized. So as we kind of go hunting for things, you know, at what point do you say, gosh, you know, I wish this patient would have been referred to me, you know, 5 years ago, or, you know, this is very mild. They could really be, you know, followed by their cardiologist.
Right. So, well, excellent question. Let me just say off the bat, I've always thought my number one referral base should be cardiologists. And I think even more so now, and I will tell you it's less than 10%. So so I'm glad to hear that you guys are asking about sleep. And I know that in the big picture, someone who just had a heart attack or who has, you know, bad heart disease, you're trying to just keep them alive in the moment, and sleep might not be on your list of things to ask about, but I'm glad that it's getting there. And I know a lot of primary care doctors now put it in their standard questions in what we doctors call the review systems. So a good night's sleep has a lot to it, right? So somebody who isn't sleeping well, they're most likely in our society, it is just bad sleep habits. The TV's in the bedroom, they have their device in bed with them, they're reading with a bright light next to them, they don't get much exercise or light exposure during the day, they drink a lot of caffeine, they eat too late at night, they drink alcohol. There's now, the bigger thing we have now is people are smoking marijuana, which helps them relax and go to sleep, but marijuana also has some downstream consequences of not getting the right amount of different stages of sleep if you're really doing it right before bed. So we have all kinds of things sort of happening together with sleep. So cleaning up sleep habits is my first approach to just about anybody, and trying to make sure they have a comfortable, quiet, dark sleep environment, right? Those are sort of big things. And cardiac patients have a lot of anxiety. If they've already had a heart attack, or they know they have heart disease and are at risk for, or higher risk for a heart attack or something like that, they have anxiety, and that can interfere with getting good sleep. But what I would say is, if you have a patient with cardiac disease or any of those things I listed, as well as atrial fibrillation, they should be screened for sleep apnea. I mean, a home sleep test is easy. Going into the sleep lab nowadays because of COVID is a bit of a challenge, but a home sleep test is pretty easy, and we usually get the results fairly well out of that. They're not 100%. So you can't, if you get a negative test, it doesn't mean they don't have sleep apnea, but we can usually pick it up on a home sleep test, and then we get them treated, and that's very helpful.
And I think the home sleep study is usually an easy sell for.
Yeah, it's easy.
So,
yes.
So is that usually a good starting place for most of us?
Absolutely. The only thing I'm going to say is, if you get a home sleep test and you get a negative result, then they have to have an in-laboratory test if you are worried they have sleep apnea, because it doesn't rule it out.
Okay. The other question that I get a lot is, you know, 15 years ago, I was told I had sleep apnea and I couldn't tolerate anything. So at what point do we just start fresh and reevaluate?
Immediately, yes.
Okay. Yeah.
So I literally just had that patient a week ago. It was 7 years, but they had tried the CPAP, you know, basically insisted it be taken away because they hated it so much. And then now feel so bad that they're willing to come back and work on it. And the devices and the masks change every year. There's something new every year to help with patient comfort and to help with adherence to therapy. So I'm happy to work with people. I have a couple good home care companies that will really work with patients to make sure it's as comfortable and easy for them as possible.
So that is so wonderful to hear. And I know there's a number of my patients that are logged on that will be calling the office, you know, and looking for that contact, because I do think there's maybe a disconnect from the trial that was maybe short-lived and incomplete and now decades old, right? And where we are now.
Oh, yeah.
And
no, I mean,
now,
I think It's like anything else. I think just think to yourself, you have to go home with this device. Now it has to be in your bedroom. You got to put it on your face. You got to rinse it out in the morning. And if you don't feel better after having that machine start, you don't buy in, right? Most patients will not keep using it if they don't feel better. And so that's a hard piece to sell too, is that sometimes it takes months before you actually feel like things are improving. So I think there's no substitute for someone who will spend some time working with a patient to help them get used to it, because it is not an easy thing. I tell patients that all the time. I know that. I don't think this is going to be, it's a change in your lifestyle, and we have to like work together to make it work.
Great. Do you know of a cleaning device called Lumen? Can you comment on that?
Yeah, I think that one uses the ultraviolet light, which also the FDA has issued a warning on. And I would tell people, if you have any worry about these cleaning devices, is to just don't use them and use warm soapy water. It takes little to no effort once you start, right? So it's just, you have to make yourself do it. But it's like if anyone had a water pick or something like that, you got to just get used to cleaning it. You run it through the shower or the sink, hang it up over the towel rack, and that's all you need to do. It's not a lot. I know it's more than what you're used to doing, but it's not a lot.
Okay. But ultraviolet, in theory, if you're not exposed to it.
If you're not right next to it, it's the same thing with the ozone. But nowadays with COVID and people working from home or staying home, they're in the same room or the same apartment with the ozone, so it might not be good for them.
Okay.
But in the old days, when you put it on and you went out of the house for the day, it probably was fine.
Okay, great. I have another question about the mouthpieces. So that sounds like you have to go to a special dentist or an oral surgeon, get it fitted. Is there anything over the counter that someone could buy to try? Doesn't work.
No, so there are sort of your make your own, but there's no way to know with the adjustment that you're doing it right. And you can also sort of risk changing your bite and stuff like that. So I recommend, there are great dentists here at the Harvard Dental School. There's, just to give people a couple ideas, there's the Tufts Dental School has a good group. I use Dr. Gail Demko, who is, I believe, out of Weston and Newton. Demko, D-E-M-K-O. I use her a lot. New England dentists, that's what they're called. They're all very good, but you want to make sure you have a dentist who does sleep devices frequently, because there's many of them and they have to be adjusted properly. So you don't want somebody who is a regular dentist and does one a month. You want somebody who does this as a bulk of their practice.
Got it.
They know what they're doing.
Okay, we'll share that name after, and we'll also share Dr. D'Ambrosio's contact number, because I think some of you are asking, who would you call to get help with a complex issue? Somebody like you, right? Someone who specializes in this. Okay.
Yep, absolutely.
All right, thank you. Allison, do you want to take the next one?
Sure. So that's so helpful. There are a couple questions here about the CPAP versus the BiPAP. Do you want to maybe just clarify on some settings?
Yep. CPAP is continuous positive airway pressure. That means air is going in all the time. So it's just opening up your throat, right? That's all that CPAP does, is just open your throat. BiPAP pushes more air in at a higher pressure when you're trying to take a breath in, and then lowers the pressure when you're exhaling. And so BiPAP can actually help you breathe a little bit. So not just opens your throat, but it also helps you breathe. BiPAP is good for people who need a little help with their breathing. So those are typically patients with COPD. If any of you have COPD, you might be on BiPAP for that reason. It's also good for people who, like I said, have that belching in the morning. That's one of the way we treat it, because there's too much air going in the stomach. Or if you just can't tolerate the high pressure for the CPAP, you feel it's hard to exhale against it, then we will switch you to BiPAP to make it more comfortable.
And when you're watching patients, right, you get some feedback from their CPAP machines. Maybe you can just explain a little bit about how you overview kind of what's going on. Right.
So not that we're Big Brother or anything. My patients always think I know what happened the night before. Like, they'll call me and say, "Did you see last night?" And I'm like, "No, I don't look every day." But I do look if I'm worried about you. And the machine has a wireless modem. And it can tell me if your sleep apnea is treated. So it tells me how well your throat stays open. And it can tell me if there's a leak in the system. And it can tell me how many hours you're using it. And that the hours you're using it is important, number one, to make sure you're getting the benefit you need from it. But it's also, unfortunately, something that insurance companies watch as well. And so you have to use it a minimum number of hours a night and so many nights a week for them to continue to pay for it.
Got it. All right, I have a question here about, I'm using a dental appliance for sleep apnea. It's okay, but sometimes I get a very dry mouth. The doctor gave me a brand called GC Dry Mouth Gel. Any other suggestions? So for the dry mouth.
Yeah, saline jelly, yeah, works pretty well. Or the ocean spray, and you can just have it at your bedside and give yourself a couple little sprays if you wake up with a dry mouth. It is hard. Dry mouth is difficult, especially with a dental device. Like with a CPAP and dry mouth, we do the full face mask and we add the humidifier, and that's a little bit easier. But for the dental device, your mouth is just going to be a little open, so you need that spray right at your ready. Just write it on the bedside stand.
And maybe if you up in the night, do it a few times. Would having a humidifier in the room help too?
No, I usually don't recommend that just because those tend to get moldy inside and the filters need to be changed. So the humidifier in the house can be a source of bacteria rather than helpful.
Okay, good to know. Thank you.
And it's probably important to mention too that this is really a process, right, to get this down and to understand your own physiology, right? I mean,
yes.
I know from seeing the impact of treating the apnea on heart failure and arrhythmias that it takes, 6 to 9 months before we start to see a steady state.
Yes.
Anything else you would add?
No, absolutely. And it's a lifestyle change, right? So I think, even taking medicine, people aren't as good about taking their medicine exactly the way they're supposed to every day. I am definitely one of those people who, if I get an antibiotic prescription, by day 5 or 6, I start forgetting that I need to take it because I'm feeling better and and I go about my day and I forget about it. So this is one of those things where you really have to make it part of your daily routine. And I think feeling better helps, right? So if you know that, so I have some patients who are like desperate that their machine never leaves their side, like they'll take it with them anywhere, right? They literally, if they're going anywhere in the car, they bring the machine with them just in case they get stuck somewhere. Like in the winter, they won't sleep without it. But that's rare. It's most, and so I love it when people recognize that it's helpful and it's important, but it takes a long time. It's like anything else. If you start an exercise routine and you've never exercised in your life, you have to make a commitment to it. Healthy diet, all those things. When people really decide this is going to improve my health and make me feel better, it takes a while. And then over time, it becomes a routine. And that's your routine and you do okay. But I get it. The first couple months are really tough to keep going.
And that brings up an interesting point. Do we have any data on the role of exercise in patients with sleep apnea and improving outcomes?
Yeah, absolutely. So exercise definitely is helpful overall for anybody to sleep. So even 10 to 15 minutes of doing 1 pound weights, curls, right? 1 pound weight curls can improve people's sleep. Unbelievable, right? Something that simple can really get you the deeper, more refreshing sleep. But exercise itself tends to make people get we think it's more of they get into routines and habits that are healthy otherwise when they start exercising, and hasn't been completely teased out. We know it improves their sleep overall, but it does improve their sleep apnea. Weight loss definitely improves sleep apnea. Even a 10 to 20% weight loss can significantly reduce the degree of sleep apnea.
So that's great. All those things also benefit people's hearts. So I think there's direct overlap with how these systems, interact with each other, and is really important message.
Yeah, it sounds like the more the better. The more you use it, the better it fits, the better. A little bit's better than nothing. But there are a couple questions in here. Someone who's using their CPAP but still fell asleep at the wheel and got a car accident, someone else who can only work up to a few hours a night. What should they do if they've sort of plateaued in terms of being able to use that CPAP and maybe not getting the full benefit?
Yeah, so I think, so the person who got into the car accident absolutely needs to see a sleep specialist. I'm not sure what's happening there, but that's scary, and I don't want that to happen to them again. And that probably is a list of 20 questions I could ask them right now to try to tease that out. But the person who can only use it about 2 hours, I would wonder if the pressure's too high, because at around 90 minutes to 2 hours is when you get back into the light stages of sleep. And if the pressure's too high, you're going to wake up, and then you're not going to want to put that thing back on your face or be able to fall back asleep with it. So a lot of times with those patients, I will adjust the pressure a lot. Some patients actually need, for a short term, like a week or two, a little sleeping pill to reduce their waking up, just to get used to sleeping through that 2 hour period and getting to 3 and 4 hours. And then we get rid of the sleeping pill and they're used to it and they can do it.
Great.
But there's a lot of things we can do for that person.
Okay, perfect. Someone is letting us know that Dr. Demko has retired and another doctor took over her practice. Okay.
Yes, I can't think of her partner's name, but I know who it is. But I do send people to that practice, and I've had good results with that practice.
Okay, perfect, thank you. And what about, can you comment briefly on central sleep apnea as opposed to obstructive sleep apnea?
So if you go back to my picture where the chest and the belly were trying to move, but there was no airflow. So in central sleep apnea, the chest and the belly don't move and there's no airflow. And that means that there's no signal from the brain to take a breath, right? So the brain is not sending the signal, time to breathe. So why do patients have that? Well, there's definitely neurologic reasons why people have it, but cardiac reasons. So heart failure is the number one. So if your heart failure is not as tuned up as it can be, you will have central apnea most likely. And that's just the, it's hard to explain, but it's just the physiology of heart failure and the time it takes for your brain to get the signal about oxygen levels, and it's just a little too slow, so it doesn't get the signal to take the breath. And so once we treat your heart failure and your heart is pumping as optimally as it can, the central sleep apnea goes away.
So it has to, and if it's not that, and that's not treatable, it's treated completely differently, right?
Right. So if it's not heart failure that we can treat and improve and get rid of the central sleep apnea, then we put people on typically BiPAP with what we call a backup rate, which means when they don't take their own breath, the machine gives them one.
Great.
And, you know, this has been such a fun discussion for our patients. And I think it really, you know, the severity of this is really under-recognized. So I expect that we're going to be getting, you know, a lot of messaging tomorrow. Maybe just your parting thoughts on things that would minimize those apnea periods in patients that do have sleep apnea, like maybe just a few words about sedatives and sleep medications and alcohol.
Yes, please, if you have sleep apnea and either can't tolerate treatment or you haven't been treated yet, please avoid any sedating medicine or substance, right? Alcohol, even a glass of wine at dinner can make your apnea much worse and can dull your brain so that you don't wake up in time and your oxygen level goes dangerously low. Marijuana can blunt that response as well. I know a lot of people are using marijuana for anxiety and for other pain syndromes, and that can really blunt your brain's ability to pick up that the oxygen's going low and to wake you up to open up your throat and take a breath. So any substance that alters your brain functioning can be bad for sleep apnea. If you are being treated, a glass of wine with dinner or something like that's probably okay. But if you're drinking a lot, if you're having 2 or 3 beers, a whole bottle of wine, your CPAP is helping, but it's not treating it entirely. And so you may need to, there's a way to adjust the machine that it changes the pressure based on what you need. And so a sleep doctor could help you figure that out. If you're someone who likes to watch the game on Sunday and has, you know, a bunch of beers with your friends, we can work with you on that. And so my parting words is, please take this seriously. If you snore, if you know someone who snores, I can't tell you how many times I've been at a party or in a situation and somebody's making fun of somebody else, all in good, good humor about their snoring. And I just sit there going, do I say something or do I not say something? Right? Like, am I going to be the wet blanket on this party? And it's important. If you're snoring, if you have heart disease, if you're a woman and you're postmenopausal and you're losing your energy, these are things where you want to like start asking your doctor or come to see me and we can tease it out.
Wonderful. That was such a wonderful lecture. So okay. I'm sure there would be lots of applause. We're all still adapting to this virtual arena, but thank you so much for joining us. Thank you to everybody that tuned in today, and we'll send out information for those questions we didn't get to with some of the other answers in the follow-up. And then we have another webinar planned for next Wednesday, so hopefully we'll see you all back then. All right. Thank you.
Thank you, everybody.
Thank you.
Bye-bye.
Bye-bye.